In this presentation, we will review radiographic image analysis guidelines for femur projections, as well as conduct a few image analysis ourselves. For the proximal AP femur projection, image analysis guidelines state that the ischial spine should be demonstrated aligned with the pelvic brim. The obturator foramen should be demonstrated as open. The femoral neck is demonstrated without foreshortening. The greater trochanter is demonstrated in profile laterally. The lesser trochanter is superimposed by the proximal femur. The long axis of the femoral shaft is aligned with the long axis of the exposure field. The proximal femoral shaft is demonstrated at the center of the exposure field. The proximal femoral shaft, hip, and surrounding soft tissue should be included within the exposure field. Any orthopedic apparatus located at the proximal femur or hip is included in its entirety, and 2 inches of overlap is evident with the distal AP femur projection if the entire femur is imaged. Now let's review image analysis guidelines for the AP distal femur. The anterior and posterior margins of the medial and lateral femoral condyles should be aligned. The long axis of the femoral shaft is aligned with the long axis of the collimated field. The femoral shaft should be demonstrated without foreshortening. The medial femoral condyle is distal to the lateral femoral condyle. The distal femoral shaft should be demonstrated at the center of the exposure field. The affected leg should not be demonstrated on the projection. Distal femoral shaft, surrounding femoral soft tissue, knee joint, and 1 inch of the lower leg are included within the exposure field. Any orthopedic apparatus located at the distal femur should be included in its entirety, and 2 inches of overlap should be evident with the proximal lateral femoral projection if the entire femur is imaged. Let's talk about rotation in the AP distal femur. If the leg is externally rotated for an AP distal femur projection, the femoral epicondyles are not in profile. The medial femoral condyle appears larger than the lateral femoral condyle. As you can see here, medial appears larger. And the tibia superimposes more than 1/2 of the fibular head. So you can see the tibia, or the fibula is completely superimposed by the tibia. In order to correct this, we need to decrease that external rotation until the epicondyles are parallel with the IR. Continuing our conversation of rotation, this image is a projection to demonstrate to you distal femur internal rotation. I understand the projection looks more like a knee, but this is just to give you an idea what internal rotation looks like. They did not provide any other image that looked more like a distal femur projection. So we're going to go with it. In this image, if the leg was too internally rotated for an AP distal femur projection, And the femoral epicondyles are not demonstrated in profile. Once again, the lateral femoral condyle appears larger than the medial femoral condyle. And you can see that here. It's appearing larger. Also, the tibia superimposes less than 1/2 of the fibular head here, as you can see. So therefore, in order to correct this, we need to decrease that internal rotation so that the femoral epicondyles are parallel with the IR. Let's talk about external leg rotation in the AP proximal femur. I have two images here. You can see the first is with the foot at a 45-degree angle here. And we can see that on external leg rotation, the femoral neck inclines posteriorly and is foreshortened on an AP projection. You can also see that the lesser trochanter is in profile. In this projection to the right, where the foot is actually vertical with the IR, the femoral epicondyles are approximately a 15 to 20 degree external angle with the IR. The femoral neck is only partially foreshortened here, and the lesser trochanter is demonstrated partially in profile. And in each projection, we just need to ensure that we rotate those toes in 15 to 20 degrees so that we can demonstrate the appropriate AP projection of the proximal femur. In this AP femur practice analysis, we can see that the lesser trochanter here is demonstrated in profile, which should indicate to you that the leg was externally rotated. In order to correct this, we need to internally rotate that leg until the foot is tilted at a 15 to 20 degree angle, and the femoral epicondyles are positioned parallel with the imaging table. We're going to now review radiographic image analysis guidelines for the lateral projection. Radiographic image analysis guidelines for the proximal lateral femur projection state that the lesser trochanter should be demonstrated in profile medially. The femoral neck and head are superimposed over the greater trochanter. The femoral shaft should be demonstrated without foreshortening. The femoral neck is demonstrated on end. The greater trochanter is demonstrated at the same transverse level as the femoral head. The long axis of the femoral shaft should be aligned with the long axis of the collimated field. The proximal femoral shaft should be demonstrated at the center of the exposure field. The proximal femoral shaft, hip joint, surrounding femoral soft tissue all should be included within the collimated field. Any orthopedic apparatus located in the proximal femur or hip should be included in its entirety, and 2 inches of overlap should be evident with the distal lateral femoral projection if the entire femur is imaged. Now let's talk about radiographic image analysis guidelines for the distal femur. Guidelines state that the anterior and posterior margins of the medial and lateral femoral condyles should be aligned. The long axis of the femoral shaft is aligned with the long axis of the collimated field. The femoral shaft should be demonstrated without foreshortening. The medial femoral condyle will be demonstrated distal to the lateral femoral condyle. The distal femoral shaft should be demonstrated at the center of the exposure field. The unaffected leg is not demonstrated on the projection. The distal femoral shaft, surrounding femoral soft tissue, knee joint, and 1 inch of the lower leg are to be included within the exposure field. Any orthopedic apparatus located at the distal femur should be included in its entirety. 2 inches of overlap should be evident with the proximal lateral femoral projection if the entire femur is imaged.
Let's take a look at insufficient and excessive femur and pelvis rotation and how to determine which is which. If the femoral epicondyles are not rotated enough to be placed perpendicular to the IR for the lateral proximal femur, the image will demonstrate that the greater trochanter is not positioned beneath the neck and head, but is partially demonstrated laterally, as you can see here. Also, the lesser trochanter is partially demonstrated medially, as you can see here. As you can recall from image analysis guidelines for the lateral projection, the lesser trochanter should be demonstrated in profile medially, and the greater trochanter should be demonstrated at the same transverse level as the femoral head. So this image here is demonstrating insufficient femur and pelvis rotation. In excessive pelvis and femur rotation, where the femoral epicondyles are placed or rotated more than needed to be, the greater trochanter is partially in profile medially, and the lesser trochanter will be obscured on the resulting projection, as you can see in the resulting image to the right.
Let's talk about the characteristics of distal femur rotation. If the femoral epicondyles are not positioned perpendicular to the IR, the lateral projection will demonstrate one femoral condyle anterior to the other. In the first projection here, we can see that one of the condyles is anterior to the other. We also know that the medial condyle sits distally to the lateral condyle. In this first projection, we can determine that when the medial condyle is posterior to the lateral condyle, the leg is internally rotated. In order to correct this, we need to externally rotate that leg until the epicondyles are perpendicular with the IR. In the next projection, we can see that the medial condyle is actually anterior to the lateral condyle. This should indicate to you that the leg was externally rotated too far. In order to correct that, we need to internally rotate that leg until the epicondyles are, again, perpendicular with the IR. We know for patients with suspected or known fracture, we won't be moving or rotating that leg. So therefore, it requires a cross-table lateral or axiolateral projection. I'm just demonstrating here accurate positioning for that projection. However, we will cover radiographic image analysis guidelines in the hip and pelvis section of the presentations. Let's review this distal lateral femur image practice analysis. We can see in this analysis that the medial condyle here is sitting anterior to the lateral condyle, which indicates to us the leg is externally rotated too much. We need to internally rotate the leg again until the femoral epicondyles are positioned perpendicular to the IR. In this proximal lateral femur practice analysis, you can see that the greater trochanter is actually demonstrated posterior, and the lesser is not even seen on this image. This should indicate to you that the leg was not internally rotated. In order to correct this image, we need to internally rotate the leg until the femoral epicondyles are positioned perpendicular to the IR. This concludes our femur presentation. If there's any questions or you need any additional help, please feel free to email me or bring it up at clinic while I am out there with you. Thank you for participating in the presentation.